Good morning, everybody. It's my pleasure to be with you, at least with this pre-recorded talk, which is dedicated to emerging and new treatments in generalized pustular psoriasis. These are my disclosures. When you speak about treatment in generalized pustular psoriasis individuals, it's very important to keep in mind a few major features of the disease. First, it's a mainly acute disease where immediate or very short-term efficacy is mandatory, especially in patients with the life-threatening disease attacks. Secondly, when we assess and when we evaluate any drug intervention, we have to keep in mind that the acute flares are spontaneously, partially or sometimes completely self-remitting, making it challenging to interpret what relates to the drug intervention. And also the rarity of the disease explains the very weak evidence, if any, for the classical drug intervention, especially the treatments which are currently approved for moderate to severe plaque psoriasis, but have been used in daily life to treat some patients with GPP. And these are literature review from the National Psoriasis Foundation experts from 2012, but the situation didn't change much with the new biologics, reflects that with conventional systemic treatment, such as cyclosporine, but also biologics available at that time, like infliximab or adalimumab, you can see that the level of evidence for efficacy is very low. The highest level is for 2A for retinoids, so quite weak evidence anyway. And again, for the TNF-alpha blockers and cyclosporine, although they are used in patients with GPP, this is based on very weak evidence, relying on case series, isolated cases. And this is also reflected in these nice guidelines for the management and treatment of patients with the generalized pustular psoriasis under the auspice of the Japanese Dermatological Association, published in 2018. And to make a long story short, the highest evidence you can see on this pink box for with a degree of recommendation, which is B, quite a high level, is for corticosteroids in life-threatening indications such as acute respiratory distress syndrome resulting from GPP or cardiovascular complication. So aside from these life-threatening indication requiring corticosteroids, you can see that as for TNF inhibitors, methotrexate, cyclosporine, retinoids, there is very low evidence, if any. And even if the IL-17 blockers are approved in Japan, this is based on open label prospective trials. So a turning point in the drug development in GPP is surely lead us back in 2011 when there was a deciphering of the genetic architecture of GPP. And to make a long story short, this homozygous or composite heterozygotes of alpha-6RN gene you will hear about today, leading to a deregulation of the IL-36 inflammatory pathway and an upregulation of the IL-36 agonist you can see here in red, and that ligate to the receptor to induce the uncontrolled inflammatory cascade. So a natural path for the drug development was to try to inhibit this inflammatory cascade, either by a recombinant form of the antagonist or by anti-IL-36 receptor antibodies. And again, the reason why pustular psoriasis patients, and especially GPP patients, are reluctant to conventional or biological treatment of proven plaque psoriasis is that the pathogenesis scenario is different in two diseases. Again, to make a long story short, the IL-36 pathway is engaged very much upstream of the inflammatory cascade in generalized pustular psoriasis. Whether the IL-23 and IL-17 and TNF-alpha and the IL-1 inflammatory pathway are more secondary inflammatory transducer, if you wish. While in the plaque psoriasis scenario, you have the IL-23, IL-17 pathways driving the inflammatory cascade. This is a major difference. So the key question was, is there a place for IL-36 inhibition for the treatment of generalized pustular psoriasis? There were some hints prior to the development of IL-36 inhibitors with other IL-1 family inhibitors, because IL-36 belongs to the IL-1 family, as you know. And in a disease which mirrors the deficiency of IL-36 receptor antagonists, but which relates this time to the deficiency of IL-1 receptor antagonist, a disease called DIRA, which is occurring in infants and children and adolescents. In DIRA, it has been shown that the infusion of the recombinant form of IL-1 receptor inhibitor reverses the skin, very much GPP-like skin symptoms, but also the joint and bone signs they can see with some osteolytic devastating lesions, indicating that a repression, an inhibition of an IL-1 agonist member was leading to clinical improvement, and very rapidly. So the question was, is there a mouse model that could guide the clinical development in humans? And yes, thanks to the group of John Sims and Jenny Towney at that time, the mouse model of DITRA resulting from the invalidation of the IL-36 receptor antagonist coding gene and the transgenesis of the agonist, the administration of anti-IL-36 receptor, you can see here compared to the control isotype, was reversing the very much GPP-like skin phenotype with severe neutrophil efflux in the isotype control treated mice, while the intraperitoneal administration of anti-IL-36 receptor was leading to the reversion of the inflammatory phenotype. And the same way, the knockout of the receptor here on the upper right was leading again to major skin changes compared to the presence of the IL-36 receptor, with the absence of inflammatory cells and of thickening of the epidermis and all the skin changes that you see in the other box. So yes, the mouse model was a natural guide for the design of anti-IL-36 receptor antibodies. This has been performed with first mouse administered mouse anti-IL-36 receptor antibodies, so murine antibodies, administered safely in different models of animal models, paving the way for the first in-disease study, a proof of concept study with a humanized monoclonal anti-IL-36 receptor antibody. And this was performed by Boehringer Ingelheim with a drug called spesolimab, and a single intravenous infusion in 7 GPP patients, only 3 of whom carried the IL-36 RN mutations, led to a dramatic and very rapid improvement of their global GPP PGA score. And 5 out of the 7 patients achieved the GPP GA score of clear, almost clear, only 1 week after the infusion, 1 week, and all of them at week 4, suggesting, because this was a proof of concept study, open label, no control group, with which efficacy was not the primary endpoint, with safety, which was fine, and all indicating that IL-36 receptor blockade was indeed suggested to be effective in this setting. So the key step of the development was to go one step further and to have a phase 2 multi-center placebo-controlled trial spesolimab in acutely flaring GPP patients with moderate to severe disease, so at least a GPP-GA score of 3 or more. And again, 51 patients randomized according to a 2-to-1 ratio versus placebo, and you can see that there is a randomized period of only 1 week, and the primary endpoint was that at 1 week, a GPP-GA postulation subscore of 0, and a key secondary endpoint was the GPP-GA clear or almost clear status at the same time point, meaning day 8, even though the study was across up to week 28. You can see the characteristic of these patients. I will not go too much into details. The severity was comparable in both groups. The mutation status, a minority of the patients were found mutated, and this was very well balanced across the 2 groups, which is very important. Only 14% and 11% of the patients mutated, so the majority unmutated. And you can see on these slides the efficacy key results showing a striking superiority according to the primary endpoint with a GPP-GA postulation subscore of 0 at week 1 in 54% of the patients receiving spesolimab at the first infusion, while in the placebo group, only 1 patient, so 6%, reached this status. And the difference was heavily significant, statistically significant, and this was also true for the key secondary endpoint. So the proportion of patients reaching a GPP-GA a total score of 0 to 1, again at week 1, 43% versus 11%. And the safety was overall good and acceptable, but 2 cases of drug reaction with eosinophilia and systemic syndrome were reported. One unlikely according to Euroscar criteria, and the other one plausible. So this doesn't say that it's related, but needs further exploration in the ongoing trials. And these ongoing studies are applied for spesolimab. This is currently investigating the capacity to prevent the flares, including mainly adults, but also adolescents. And there is another anti-IL-36 receptor humanized antibody in imsidolimab developed by Anaptys Bio. The phase 2 have been completed, but not published yet, and the phase 3 are ongoing. And just to show you that what applies for GPP doesn't necessarily apply for all pustular variants of psoriatic disease. This proof of concept placebo-controlled study performed with spesolimab, 2 doses versus placebo. It didn't show very much of a difference compared to placebo across 16 weeks. So it doesn't seem at this stage that IL-36 blockade works as well in palmoplantar pustulosis differently from GPP. So this is opening the door for that genetic heterogeneity with some different genetic backgrounds that you heard about today. Are paving the way for precision medicine approach, and IL-36 receptor blockade is not one size fits all for all pustular variants of psoriatic disease and beyond. So to summarize, there is little evidence, if any, for the efficacy of drug currently approved for moderate to severe plaque psoriasis in patients with GPP. The deciphering of the genetic architecture of GPP unraveled the pivotal role of IL-36 in the disease pathogenesis and paving the way for the IL-36 inhibitory drugs development. The initial steps of this very development already provided promising results in GPP across different genetic backgrounds, but it's worth reminding you that no IL-36 specific inhibitor is currently approved in any human disease indication. I would like to thank you for your attention.